Well, I'll switch to Czech. I'd like to most welcome you on the occasion of this panel discussion. We will talk about novel therapies seen through cost effectiveness. Whenever you see pricing or innovative or simply novel, you immediately know it's gonna be pretty tough. We shall first talk with the Czech expert, namely the head of the Patients Council, Madam Arnoštová. Hello. We will also talk with Mr. Stanislav Militinsk, who is a psychiatrist and also a head of Zion, that is a, so to say, breakthrough activity that helps to promote the Ph.D, psychedelics assisted therapy. And also to introduce myself. Well, first, Jiří Mrázek, I'm to introduce, who is in charge of disbursement of healthcare, and he is, as we have already said, the director of the healthcare department for GHI company VZP. By way of introduction, let me say the following. I was appointed the facilitator of this panel because I've been always strongly interested in this thing. We have very many cases of people who are not diagnosed for their mental health. Plus, there is also a huge number of TR-resistant people, simply people resistant to the treatment, plus TRDs, also depressions. And we also get information from US and Australia that psychedelics-assisted therapy may be one of the ways to help healthcare system to deal with the load of burden. I am mainly interested in economic impact, since I'm an economist, which consists in the better productivity associated with the demographic curve and aging now, which doesn't look promising either on the demand or supply side, which in the Czech Republic is a major issue. Second, it could also help reduce the stigmatization of mental health treatment of those who, vis-a-vis those who are ashamed, so to say, of that. And also the studies or trials, there are not trials enough, but those of us who are involved in this topic, they are difficult to be approximated to the situation in the Czech Republic. So, economic impacts may rest on three major pillars: savings, cost savings of traditional treatment, reduced admissions to hospitals, and limiting absenteeism. That means absence of a worker in a workplace, or presentism, which means that the person is mentally absent from the workplace. Whether this is the case or not, and was the potential, well, let's ask our specialists or experts. The first question that will be kind of general, I wish to ask, what is it that the payers actually lack with respect to the novel mental health treatments or innovative procedures? Innovative procedures mean, well, cover just about everything and anything. It's not just the novel treatments. Well, I'm here not on behalf of the payers, but this is a tricky question. I thought we would have other questions rather associated with the mental health care. The disbursement or system of disbursement in this country is pretty rigid, which we can understand because the measurable criteria presented by regulators and payers are, in my point of view, pretty cumbersome, hardly ever measurable, or sometimes not measurable, and when it comes to psychiatry, difficult to measure. Each and every person is different, each patient is different, and new therapeutical processes and disbursement by the payers or the Ministry of Health, and well, that's a long distance run. And I have to say that not always there is willingness and ability to reflect the costs incurred by these novel therapies. I'm a lawyer, so the Act on Public Health Insurance talks about impacts on budget. Section 15 or what, sorry, we don't have anything from the lady. And it doesn't fully reflect what is necessary to be enshrined in the law or implementing decree, which enlists all the medical or healthcare interventions. Well, it's more, so to say, aimed at those who are willing to meet the criteria. I don't want to speak for long, so I believe I'll hand over the floor to our General Health Insurance Company representatives. The list of interventions relates to what is partially disbursed or fully disbursed, but usually there is quite some time before the new methods are reflected. And it's paid through different or based on different provision where 3 conditions have to be met, and it's more up or down to the healthcare professionals or providers of healthcare who have to fully justify these novel treatments or innovative procedures, and the burden of justification rests with them. As is usual in healthcare service, the last to speak or last word will be given to the General Health Insurance Company. Well, I asked about the barriers or what's missing or what's an obstacle to the novel therapies. I believe coverage. Well, I wasn't here in the morning since I was participating in the final round of negotiations concerning disbursements. We have reached an agreement there. I believe we shall reach agreements with some other stakeholders, which would be great. But these negotiations covers, I don't know, 55%, 25% of the costs are drug-related costs or drug medicinal products costs. First, prescription drugs, and the other especially accounted for supply, which means those supplies that are purchased by the providers. And naturally, there are some other supplies or apart from medicinal products or drugs. So it is extremely interesting to follow the structure of the 75% of costs that are being negotiated now, since the costs, a majority of costs, are costs on staff, so wage costs or personnel costs, and that in order to find the balance or strike the balance, whenever there are funds left over, or we can either allocate them or invest them in innovations or pay the staff, or we can even pay the staff more or an amount that exceeds the disposable or available amounts of money. There is also an institute of risk-sharing contracts, which doesn't apply to drugs only, but to care, generally speaking. When it comes to drugs, we use this risk-sharing a lot, and we try to also apply that to other types of care, like primal implants of joints or transplants, endoprothesis, and the provider provides a guarantee or warranty for quality of care for a certain period of time. Out of 100 potential providers, only one accepted this. In other words, willingness, or rather lack of willingness, to go for risk sharing is not there. And by that we get faster feedback than when we focus on quality assessments. The previous presentation clearly illustrated all kinds of quality, approach to quality, and its breakdown into social medical dimensions. But the direct risk-sharing contract, I believe, is the best to verify or check the cost-effectiveness or lack of cost-effectiveness of the given care. The providers, or who are the license holders, are not always willing to go for the risk-sharing contracts. Thank you.
Thank you very much. I would like to ask Mr. Miletinsky. We just spoke about the fact that society has contracts with 6 healthcare insurance companies. So what's the position of the provider? Thank you very much for giving me the floor. So maybe I should introduce myself. We are a non-governmental healthcare facility, and we are really pleased that we have made contracts with 6 healthcare insurance companies, including the general healthcare insurance company, VZP. And of course, we are monitoring situation in abroad, what they are doing. Their models proved to be not much functional, and since we are common outpatient clinics providing standard care to about 80% of our patients, because the standard care works well, and at the same time about 20% of our patients are provided ketamine-assisted therapy, which is a new approach in the mental health care, because this portfolio of patients are therapy resistance, and that's why we have applied the therapy modality, which really proved to be really efficient, especially in cases where other therapies fail. And in cooperation with other healthcare providers, we are offering this therapy for several times cheaper prices compared to our competition, and we are measuring the efficiency of healthcare long term. So that's why we just know that it's cost effective. Maybe we can show the slide and we see it here. So just to show you what are we talking about, Professor Horáček had spoke about it in the morning. So this is the portfolio about 500 patients, 600 ketamine assisted therapy, and 700 ketamine enriched experienced, 724 actually. 572 treatments. So we see that most of the patients experience once the ketamine-assisted therapy. So number 12 shows medium severe severity. It declines to 8, which is the light depressivity, and at the bottom we see 4 and 5s over the time, to just after the treatment, to 4 and 6 months after the treatment. So we see that the therapy is efficient over the time. For instance, the 0.2, it's called effect size, and we know that traditionally treated depression is 0.3, 0.4. While here we see a much higher effect size, which is sustainable over time, and those data demonstrate that the therapy may be available. It's quite quick. It takes 2 to 3 weeks. It can be used across all our portfolio of our patients. The oldest patient is over 80, and it's also safe if indicated well. So this is about our clinic. And we just wanted to continue, to give you an idea. Our traditional patients, it's a patient that attends psychotherapy and psychiatry for about 3 to 5 years, and in the last 2 years, the treatment brings no results, and then we apply the ketamine-assisted therapy, which is really a valuable approach. So Czech Republic, it's kind of hub for the development and research in healthcare, and our scientists often in foreign universities demonstrate great results, and quite often it is discussed that in the area of mental health and psychedelics-assisted therapy, Czech Republic may play a role of innovative hub, leading the way to other countries. For the other countries, a lot of trials and also presentations abroad demonstrated that the progress is really fast. Nevertheless, I would like to ask a question which is expected from the moderator. Do you think that the Czech Republic can mobilize resources to be able to implement a good, cost-effective study or analysis that would speed up the innovative novelty treatment in practice? And that's why we would lead the way and bound all capital investment related to research and development, or are we lagging behind and we should copy and paste the good practice and mitigate all risks related to demography that is ahead of the Czech Republic in the upcoming 10 years? Well, that's the question of resources, actually. We got some resources, and those resources are currently lower than expenditures. So currently, in the last 3 years, we developed a minus balance, difference between income and expenditures, and we need to think what to do about it. In fact, I have listened to paper of Professor Kašpárek. I deeply appreciate him, respect him, and he just talked about demographic structure of individual specialties of physician. Nevertheless, there are some disciplines, for instance, pediatricians. It's really worse. It's already in crisis, and it will deteriorate. So we are talking about accessibility of pediatric care now. So on the other hand, in the last 6 years, we have invested double budget, and the question is, what's the effect, how this money ended up? So majority of the money was spent for salaries of physicians and non-healthcare professionals. But I don't want to be in depression. Then you may diagnose me as appropriate for the ketamine-assisted therapy. So in order to avoid it, I would like to present some objective data sets looking to Europe and our purchase parity in the Czech Republic. We may see that we are now in the 16th position. Thinking about among EU countries. Among EU countries, out of 27 countries, yes. 16th position out of 27 countries. Looking to MAA report, European Medical Agency. So you'll find out that in the selected innovative molecules that EMEA monitors, we are globally in position number 11, so we are better than our economic options. So 11 versus 16th income position. And looking to oncology, we are even number sixth position. So we are just behind countries like Germany and so on. So we, in fact, are by 10 positions better than our economic possibility, options, availability is. Of course, considering the equivalent of the economic powers, we consider it to be the purchase parity and PPP. So thinking that we are at good level in Europe, and the question is, can we be leaders and can we invent some role-play solution for the others? Well, I don't feel to be that such expert to lead the way. Of course, we can profit from the good practice, and we can just add what I have suggested, clear risk sharing contract that would generate really hard and measurable and quick feedback. Thank you very much. So I would like to extend my question. So do you think that the environment in the Czech Republic and practice in the Czech Republic represents a good incubator for potential capital investment investors that may be interested to use Czech environment and Czech healthcare model to invest private money here in the Czech Republic that may lead to some project and return of investment. Yeah, Czech Republic is a long-term leader in psychedelic area, brought about Mr. Horáček research or Tomáš Páleň Czech research. So we are at really high level, and it's good to realize that Czech mentality, a modest approach, doesn't allow us to talk about our successes. We, for instance, lectured one project of modality in Iceland, and we just explained that we just conduct about 80 to 90 ketamine experiences per month, 60 to 70 patients, 50 to 60 patients, and abroad they have about 20 experiences, so they really admired the level of our care, what number of patients we are treating, and what the number of healthcare professionals. I don't want to praise ourselves. I just wanted to rather point out that care we provide is at global level, and we are leaders, no matter whether we want it or not. So we have a potential. We have a lot of experts that are willing to learn this new approach, and we also see the mind shifts of young physicians and psychologists. 10 years ago, psychedelics were considered drugs, something bad, but now psychedelics are considered as a way to generate something useful. So we have a really good environment here, and I'm pleased that you say that we are leading the innovations, and what we want to do, we would like to conduct the cost efficiency study analysis, and I believe that we are able to progress with that, and for time being we communicate really well with healthcare insurance companies. So I think I'm quite hopeful, and we can lead the way globally. So that's the optimism, definitely. And it's great to be optimistic at the conference about mental health. It's an excellent approach. Now I would like to ask Lenka Arnoštová, Lenka Teska Arnoštová. So it's good to have good institutional environment, including legislation. And I remember that since I learned how to read, I remember that I read that in the Czech Republic, the cooperation between public universities and private sectors is not good, and spin-offs that the universities may generate for industry, healthcare, and so on. So question is, do we have good institutional environment in order to cooperate well between public and private sector to generate good cost-effective studies in the area of mental health that will just bring us towards the leaders?
I'm not an expert when it comes to science and research, but at the ministry there are simply institutions like National Institute of Mental Health that focus on research, or other entities that could cooperate on that. I believe that if all these stakeholders get together, if we have sufficient budget or funds, and if the public sector gets this as a priority, when you bear in mind the lack of psychiatrists, psychologists, etc., well, then we have like pediatric psychologists and psychiatrists shortage. And that's, I don't know, there should be the 60 minutes limit. I believe she means the time you reach, within which you reach this specialist. So if we have to wait until new graduates, or if we have enough simple staff or specialists, then it would make sense for sure. I don't know. I remember we had some projects within the memorandum with St. Anna's Hospital in Brno, or I remember campus projects with the Ministry of Defense. Whether it made sense or not, I don't know. But if there is a will on the part of Ministry of Health, and then that would be useful. Also, the point is, and now I'll be very blunt, if it's just to if we fill in the gap in terms of understaffing, simply shortage of professionals, I believe that might be really meaningful and have a strong impact, and we would be the flag bearer, so to say, in this arena. Is there a question from the audience? Anything you'd like to ask about? Well, a question which is, a sentence with a question mark at the end. Or you can just as well raise a comment or observation, share it, whatever. If not, I will pose a question, and then we'll wrap up this panel. It's a hypothetical question. Just imagine you are the Minister of Health, and you have identify a black hole, or simply you go to the government meeting, you propose a measure, it's approved, it's then passed by the lower chamber, Senate, the president will sign it with no comments, and it'll be, as I've said, approved or passed. And your aim is to simply face and put up or cope with the mental health related gaps. Then you can, what should this measure look like? The politicians amongst us here may write it down if you have any such suggestion or idea. share your opinion with us, please. Well, I wondered whether to respond in a Solomon-like manner or and I don't know what I opted for. If there could be a law or an act, all the relevant topics should be decided upon by experts, and it should be based on evidence. Should be evidence-based policy making. I guess we have got such an act or law already, but compliance is the question. The regulation impact assessment. We need to know what legislation should be actually proposed, but I do understand what you mean. I know what you mean. And also expression of grief that when it comes to expert level, the topics are kind of put to popular vote, and people are asked whether diabetes incurs excessive costs or not. But I guess we could have a separate conference on that topic. Well, I'm a practitioner, so I apologize. I can't imagine anything like that. I don't think it can ever happen, because most officials at the ministry prefer to simply present or submit orders rather than anything else. And it becomes politicum frequently, and the outcome is rather to the detriment than in favor of the situation. But your question was related to mental health, wasn't it? So responsibility should also be borne by people, by individuals. People should be aware enough, should get sufficient amount of information. People shouldn't go to internet or Google things out. They should be provided early response or early assistance when it comes to mental health disorder or condition. That's a real disaster, the current situation. There should be available, affordable, quality care service or services available. And the intervention should be as prompt as possible and as effective as possible. I would need 1 hour or 2 hours to explain what I wish to say, but I'll do my best to cut it shorter. The past government and current government were been interested in psychiatry. Insurance companies were tasked to increase the budget by 300 million crowns to cover the costs incurred by psychiatric patients, and it did happen. Some in the past it was even a higher budget, or by 300 million crowns more were allocated to the psychiatry discipline as against other specializations or specialties. There were also other measures taken, but the only discipline or specialty experience deregulation. That means psychiatric practitioners and clinics aren't governed by any regulation, no limits when it comes to prescriptions or number of visits, volumes of interventions per patient, which is the case in other specialties. So in the first year, this drug switch has cost us 300 million in psychiatry only. And we keep spending more money on psychiatry care, we have the so-called, so it is a part and parcel of our mandatory expenses of expenditure. That means the expenditure beyond the increase in other segments. And as to your case or model case, that that I'm a minister and I approach the prime minister, well, it's very simple. I will simply increase the revenues in any way possible, either by payments for the so-called state systems insured persons, or a levy, which means that next time I will not be voted in. And or when you see the number of smokers downstairs in the backyard or garden, I have certain ideas, or I can think of a number of mechanisms. I guess that would be the most simple solution, but it would either result in inflation or currency devaluation. Well, I believe that's it. Even though the National Drug Coordinator raised his hands and wanted to ask or comment, but we have to wrap up. And or do we have time? So I'll hand over the floor to Indra, who asked for the floor. I've got a question with a question mark at the end, addressed to the director of the General Health Insurance Company, Mr. Mrazek. It's a bit of a hypothesis-based question again. So just imagine that a magic occurs and psychedelic drugs or PAT simply would have such an effect or prove such an effect that simply some patients would be healed thanks to PAT. While all the drugs used in psychiatry just alleviate or relieve the symptoms, antidepressant, anti-anxiolytics. And what would you, as the insurance company director, think about that in terms of, I believe he means cost effectiveness. What should it look like is my question. I don't know whether it is really understandable. Well, risk sharing with the provider, but we don't have any regulations or pieces of legislation providing for that, or for the treatment user or beneficiary. That would be the best way or means. If we manage to identify proper parameters to measure the outcome, and it's sometimes even the illusory healing or recovery, sometimes just improved or sometimes it may even be some mild or moderate worsening of the health. Well, that would be the means or the way. I mentioned the endoprothesis. The replacements, and if there is no infection in the joint within 2 years post-surgery, then there is no need to perform re-surgery. Then it's easy to measure the outcome. I believe that in the Czech Republic we are number one in Europe when it comes to measuring hemodialysis and also in risk sharing. We do pay some bonus for quality of hemodialysis, so we deduct we do analysis, chemical analysis or tests, put it in one repository, and based on that, we monitor majority, not all, but majority of patients, which in Europe and perhaps the worldwide is unique. If you take, as has been suggested by our colleague, if you do admit that quality of data is essential, is number one, where in case of hemodialysis it is guaranteed because it's direct reading from the devices. Yes, I am gonna wrap up. I always deliver lengthy responses, but suitable parameters for risk sharing and outcome measurements or assessment is a way to increase the effectiveness and efficacy. We still have time for one question. Does it make sense to actually calculate the cost effectiveness at all if risk sharing is here and if it's a universal tool? Is there a country that would only have this risk sharing approach or contract approach? What would you say? Well, there is a mix. There are mandatory legal procedures set by SUKL, that means the State Institute for Drug Control. You have to comply with those procedures, but this is an additional way to improve the cost effectiveness. And it would be an addition to the standard mandatory procedure. Well, this is it. Full stop, period. The moderator has two tasks or two roles to keep the panelists safe and then keep the time. Well, that we are not that much delayed. Therefore, I wish to thank the panelists for their input. And now we hand over the floor to our professional facilitator, moderator.